Hello everyone and welcome to this comprehensive overview of Salbutamol. I am Docsaab and your presenter. I am delighted to guide you through a detailed analysis of this critically important medication. Throughout this presentation, we will explore its chemical and pharmacological profile, mechanism of action, therapeutic indications, dosages and formulation for different patient groups, potential side effects, contraindications, usages in special populations, and regulatory guidelines. Let's begin our journey into the world of salbutamol. Let's dive into the chemical and pharmacological profile of salbutamol, which forms the foundation for understanding its clinical utility. Chemically, salbutamol is identified as 4,2-30-butylamino, 1-hydroxyethyl, 2-hydroxymethylphenol, a synthetic catecholamine derivative with a molecular formula of C13H21NO3. When formulated as its sulfate salt, commonly used in inhalers and solutions, the molecular formula becomes C13H23NO7S, enhancing its solubility and stability. You might recognize it by its widespread brand names such as Ventolin, the classic blue inhaler synonymous with asthma relief, Aeromir, ProAir, and Acunab, among others like Proventil and Salamol in various markets. These brands ensure accessibility worldwide. Pharmacologically, salbutamol is classified as short-acting selective beta-2 adrenergic receptor agonist. This selectivity is crucial. It targets beta-2 receptor in the lungs with minimal impact on beta-1 receptors in the heart, reducing cardiac side effects compared to non-selective agonist. Introduced in 1968, this class makes salbutamol a rapid relief agent for bronchospasm. Now let's explore the fascinating mechanism by which salbutamol exerts its therapeutic effects. At its core, salbutamol works by selectively stimulating beta-2 adrenergic receptors on the smooth muscle cells of the bronchial airways. These G-protein coupled receptors, when bound by salbutamol, trigger a signaling cascade that begins with the activation of adenyl cyclase, an enzyme embedded in the cell membrane. Adenyl cyclase then catalyzes the conversion of ATP to cyclic AMP, dramatically increasing its intracellular levels. This elevated cyclic AMP is a key second messenger that activates protein kinase A, which phosphorylates various targets to inhibit myosin phosphorylation, a process essential for muscle contraction. Simultaneously, it promotes the sequestration of intracellular calcium into storage sites, lowering free calcium concentrations. The net result is relaxation of the bronchial smooth muscles, leading to bronchodilation and widening of the airways, which alleviates symptoms like wheezing and shortness of breath. This effect kicks in rapidly within minutes for inhaled forms and lasts for 4 to 6 hours, making it ideal for acute relief. Interestingly, this same pathway contributes to its off-label use in hyperkalemia by enhancing sodium potassium ATPase activity. Let's cover the therapeutic indication of salbutamol, highlighting its primary roles and evolving guidelines. The FDA approves salbutamol for the treatment and prevention of acute or severe bronchospasm in patients with reversible obstructive airway disease, including exercise-induced bronchospasm, a common trigger in athletes or active individuals. In practice, it's frontline agent for acute asthma attacks, providing quick symptom relief. For chronic obstructive pulmonary disease exacerbation, where it eases airflow limitation, and for bronchoconstriction in severe respiratory infections like viral pneumonia. However, it is critical to highlight the significant shift in prescribing guidelines, particularly those updated in 2025 by bodies like the GINA and NICE. These emphasize combining salbutamol with inhaled corticosteroid, such as in MART regimen, moving decisively away from salbutamol monotherapy. This paradigm shift promotes combined inhalers or adjunctive anti-inflammatory treatments to address both symptoms and root causes, ultimately aiming to reduce exacerbation by 20 to 50% hospital admissions. In family medicine, this means routine asthma reviews to optimize inhaled corticosteroid integration. Let's focus on dosages and formulations of salbutamol tailored for pediatric patients, a group where precise dosing is vital to balance efficacy and safety. Pediatrics require age and weight-based adjustment due to varying pharmacokinetics. For oral administration, salbutamol comes as tablets 2 mg or 4 mg or syrup 2 mg per 5 ml. For children aged 2 to 6 years, the dose is 1 to 2 mg or 2.5 to 5 ml 3 to 4 times daily. For 6 to 12 years, 2 mg or 5 ml 3 to 4 times daily, maximum 24 mg per day. And for those over 12 years, 2 to 4 mg 3 to 4 times daily, maximum 32 mg per day. Extended release forms are awarded under 6 years. Aerosol inhalers or metered-dose inhalers deliver 100 to 200 micrograms per puff on demand for maintenance, but in acute attacks, 2 to 10 puffs every 20 minutes for the first hour, then every 4 to 6 hours. For children under 6 years, a spacer is essential. It increases lung deposition by up to 50% and reduces oropharyngeal side effects. Nebulizer solutions are ideal for severe cases. Under 4 years, 1.25 to 2.5 mg every 6 hours. 4 to 11 years, 2.5 to 5 mg up to 4 times daily. And for children 2 to 12 years, 0.63 to 1.25 mg 3 to 4 times daily. Injectable routes are reserved for life-threatening scenarios in children over 12. 500 micrograms subcutaneously or intramuscularly every 4 hours or 250 micrograms IV slowly. Always monitor for tachycardia in kids. Now move to dosages and formulations for adult and geriatric patients where consideration include body weight, comorbidities and sensitivity. For adults, oral salbutamol starts at 2 to 4 mg 3 to 4 times daily, titrated up to 8 mg per dose if needed, maximum 32 mg per day, though may respond to lower doses for maintenance. In acute settings, metered dose inhalers provide 100 to 200 micrograms as needed, up to 12 puffs daily. Nebulizer solution is the go-to for severe asthma, 2.5 to 5 mg every 4 to 6 hours or 5 mg via oxygen-driven nebulizer in hospitals for immediate relief. For a persistent symptoms, continuous nebulization at 5 to 10 mg per hour can be used with specialized equipment monitoring for tolerance. Geriatric patients often over 65 require cautions due to reduced clearance and higher cardiovascular risk. Start oral dosing at 2 mg 3 to 4 times daily, avoiding maximum doses initially. Nebulized forms are preferred in the elderly to minimize systemic exposure. Key caution: in those with heart conditions like hypertension or arrhythmias, salbutamol can cause tachycardia or palpitation. Always check baseline ECG and vital signs. An important off-label but evidence-supported use of salbutamol, its role in managing hyperkalemia, especially relevant in family medicine for CKD patients. Hyperkalemia can cause life-threatening arrhythmias and salbutamol provides rapid redistribution therapy. Its mechanism leverages the same beta-2 pathway. Stimulation enhances sodium-potassium ATPase pump activity in skeletal muscle, driving potassium intracellularly and lowering serum levels by 0.5 to 1.2 milliequilibrium per liter independent of renal function, making it ideal for end-stage renal disease or AKI. Onset is swift at 15 to 30 minutes, peaking at 60 to 90 minutes with effect lasting 2 to 6 hours. Nebulized dosing is preferred for safety. Adult receive 10 to 20 mg diluted in saline over 10 to 30 minutes. Children 2.5 mg in less than 25 kg or 5 mg more than 25 kg or 4 to 8 microgram per kg, maximum 500 microgram. Neonates 0.5 to 1 mg proven safe in studies. As an adjunct to insulin glucose, it is invaluable when IV access is limited or in outpatient dialysis prep. Guidelines from ACEP and KDIGO endorse it for emergent cases with ECG changes like peak T waves. Cautions include tachycardia, hyperglycemia, potential rebound hypokalemia, and arrhythmias. Let's address the potential side effects of salbutamol, an essential discussion for safe prescribing. Most are dose related and transient, stemming from its beta 2 agonism. Common effects affecting up to 10 to 20% of users include shakiness or tremor, headache, muscle cramps, and mouth throat irritation from inhaled forms, often elevated by rinsing after use. This typically resolve within hours. Rare but serious effects include cardiac arrhythmias, hypokalemia, and peripheral vasodilation causing flushing or warmth in extremities. Other notable effects are restlessness, hyperactivity, muscle tension, and chest pain mimicking angina, particularly in cardiac patients. Allergic reaction, though rare, can be severe. Hives, facial swelling, severe dizziness, or anaphylaxis with breathing difficulty. Stop use and seek emergency care immediately. In hyperkalemia treatment, watch for rebound hypokalemia. Overall, side effects are milder with inhaled routes. Contraindications and drug interactions critical for avoiding adverse outcomes. Absolute contraindication include hypersensitivity to salbutamol or its components, which can trigger severe allergic reactions. Use extreme cautions in patients with cardiovascular conditions like hypertension, irregular heartbeat, or heart failure, as beta 2 stimulation can exacerbate tachycardia or arrhythmias. Monitor ECG closely. In diabetes, salbutamol induces hyperglycemia via glycogenolysis, so frequent glucose checks are needed. For drug interactions, tricyclic antidepressants and monoamine oxidase inhibitors potentiates cardiovascular risk, including hypertension, palpitation, and arrhythmias. Consider a 2-week washout or alternatives. Non-selective beta blockers antagonize salbutamol's effects, potentially causing bronchospasm. Cardioselective ones like atenolol are safer but still risky. Corticosteroids and loop diuretics amplify hypokalemia risk through additive potassium shifts. Cardioglycosides like digoxin heighten arrhythmia potential via electrolyte imbalances. Other sympathomimetics or xanthine compound cardiovascular stimulation. In hyperkalemia, avoid with the digoxin toxicity. Salbutamol's uses in special population, where individualized care is paramount. In pregnancy, classified as FDA Category C, animal studies show potential risk, but human data, especially for inhaled forms with low systemic absorption, indicate safety. Poorly controlled asthma poses greater fetal risk, so continuing salbutamol is recommended. Monitor with fetal ultrasounds if severe. No increased congenital anomalies like cleft palate are causally linked. For lactation, salbutamol passes minimally into breast milk and it's considered safe. No adverse infant effects or fertility impacts reported. Advise pumping and discarding if concerned. In pediatrics, it's safe even under 2 years of for acute wheeze. Metered-dose inhalers with spacers are often safer and more effective than nebulizers, reducing contamination risk, especially in influenza-like illness. Dosing is weight-based, 4 to 8 microgram per kg nebulized with spacers boosting delivery by 30 to 50% in young children. For geriatrics, cautions is key due to higher comorbidity rates. Start with half doses to avoid tachycardia or falls from tremor. In hyperkalemia, nebulized forms are preferred in elderly renal patients. Let's focus on regulatory information and prescribing guidelines. In 2023, the Medicines and Healthcare Products Regulatory Agency issued a stark warning on salbutamol overuse based on data from over 187,000 patients showing that 3 or more SABA prescription annually correlates with double asthma severity and mortality risk. Overuse masks inflammation leading to preventable deaths. A pivotal shift, guidelines from NICE and SIGN no longer endorse SABA monotherapy. Salbutamol must be paired with inhaled corticosteroid to target inflammation. Combined therapies like MART or anti-inflammatory reliever are now first line for adults and adolescents, reducing attacks by 30 to 60%. For acute severe asthma in hospitals, nebulized salbutamol 5 mg every 15 to 30 minutes or continuous 5 to 10 mg per hour remains standard, obtained with oxygen. Concerns persist over online sales of salbutamol inhalers without prescriptions, undermining oversight and risking misuse. This brings us to the end of our presentation on salbutamol, including its core respiratory applications and off-label use in hyperkalemia management. I hope this detailed overview from chemical basic to regulatory nuance has equipped you with the actionable knowledge for clinical decision making, whether in asthma care or electrolyte emergencies. Thank you for your attention and engagement throughout this session. Your input and perspective are highly valued. Please like, share and subscribe to the Docsaab's Diary.